Okay, so for many of you, I suppose the first part of this presentation, which will be about sort of 10 minutes, will be quite familiar about asthma because you've been living with asthma for a long time. But for some of you, this might be something still quite new, or there may be gaps in your knowledge. And this webinar is helping you just to have that good understanding of all the things you need to know about asthma and how to live well with asthma. So, the symptoms of asthma can be quite mixed. And when we think of asthma, we think of it as a mixed condition. And by that, I mean that many patients will have symptoms that are slightly different to others. And so some patients will present in what might be thought of as a classical way with breathlessness, with wheeze, and the symptoms can come on quite acutely, often related to a trigger, whether it be pollution or pollens or animal danders, or very commonly after a viral infection, which then leads them into getting emergency healthcare. But some patients have symptoms that are much more subtle, and they've never had an attack of asthma, and the things that they see doesn't really relate to them, but they have that sensation they can't take a full breath in. So the take home is that asthma is a mixed condition or a heterogeneous condition. It can present in many different ways, and it's variable, which means that you can have good days, you can have bad days. But one thing that unites patients with asthma is the challenge that sometimes the condition can be really uncontrolled, and you can feel incredibly unwell in sometimes quite a short space of time. And therefore, even if you have quite modest symptoms and your day-to-day life is not affected by asthma, if you have asthma, it's really important that you're armed and prepared with an action plan so that you can respond to those symptoms and you know what to do and when to seek help. And webinars like this are about sort of making sure you have all the knowledge that you need. So asthma is fundamentally caused by inflammation. Now, inflammation is a term that we use often as doctors, as nurses, and in preparing for today's talk, I was thinking about how best to get across what I mean by inflammation. And then I thought about something that's very familiar to all of us, and that's when we hurt ourselves or strain ourselves, you'll often notice whether it's an ankle or an elbow or a knee, that the body responds to that injury by swelling. And you've got a picture there of a lady there who's bruised her foot, and it's become red, it's become sore, and it's become swollen. And that's a good way of thinking what's happening with inflammation in the breathing tubes. The other example is eczema, where a lot of patients have eczema, a lot of you have seen eczema, and you can see that visual idea of what inflammation looks like. It's angry, it's raw, it's red. And the same tissue that supplies our skin is also in the lining of our airways. What you see there in that picture are 3 breathing tubes. These are the bronchi. And on the left, as you see, is a normal airway, which is like a tube surrounded by tissue, which is like the skin, epithelial skin. And then you've got other tissue, and then you've got muscles around a band of those breathing tubes. In a patient with asthma, in the middle diagram, that tube becomes thickened. I think my headphones have just stopped. I hope you can still hear me. The breathing tubes become thickened, and that means that the air, the lumen, that means the diameter of that breathing tube gets much more narrow. And that can mean that airflow through your lungs is much more reduced. And that's why sometimes you can take a breath in, but actually breathing out can be really very difficult. And that's one of the cardinal symptoms of asthma, and that's what's causing it. Those airways have become thickened, sometimes with a lot of mucus, and you start coughing up some phlegm, and generally you can't get that breath in. Now, what can happen in asthma and other conditions is that you can have things in the environment such as pollens, viruses, pollution with PM 2.5s, very, very small particles that can get into the airways. We breathe them in. And in someone who has asthma, who has uncontrolled asthma, their first line of defense, which is that barrier protection, is impaired. And those small pollens, those particles from your electric vehicle with the brake dust or your diesel fumes or viruses, whatever it may be, those things that are inhaled can quickly get into the airways and cause spasm of those muscles, so that on the right-hand side, as you see it, you have a full-blown asthma attack, where the airway gets really narrowed, a lot of mucus is produced, the muscles constrict, and suddenly you find it really difficult to breathe. And that's, in a sort of cartoon picture, what's happening when you have an attack of asthma for many patients. Now, asthma, as I mentioned, it is a variable condition, and that means that some patients have a history of asthma or asthma suggestive symptoms when they were much younger. So the common thing is that they had early childhood wheeze that persisted, and into their teens they had wheeze and they were diagnosed and treated for asthma. And then what often happens is that as they get older, the symptoms become less obvious, or they don't even need medications. They don't even think that they have asthma. But at some point in the later life, it then reappears, often after an acute attack of asthma. In other patients, asthma can come much later onset in life. So it's variable. And even if you've never had a history of asthma in your early life, if none of your family have asthma, you can still have asthma diagnosed well into your later adulthood. Now, some patients have asthma and they have also upper airway symptoms. And by that, I mean a runny nose, which we call rhinitis, sometimes congestion, sometimes fullness within the sinuses, which is like sinusitis. And on the right is a sort of reminder for doctors, for nurses, that every time you see someone with asthma, to think about their upper airway. Do you also have symptoms of allergy that's uncontrolled? Could that be affecting your symptoms of asthma? And it's important that we as doctors and nurses ask patients about those upper airway symptoms. But it's also important as you as a patient, when you have asthma, if those symptoms are uncontrolled for you, or if you have heartburn or reflux, to understand that that can affect your overall control of asthma. And if you have those symptoms, it's really important to share those symptoms with your healthcare practitioner so they can help support you to best manage it. Now, some patients with asthma have a condition called Samter's triad, and that's those, if you have 1, 2, and 3 that you see there, and that's where you have that runny nose that's persistent, but also nasal polyps. And if you've never seen it, this is someone's unfortunate nostril, where you see that sort of pearlescent, almost whitish area there on that tube, which is a camera shot of someone's nostril, where they have a polyp, which is an outgrowth, which can occur with asthma. If you've had polyps, you know what it's like. It can be really hard to live with, really congested. You lose your sense of smell. Well, some patients have asthma, they have polyps, and they also have this sensitivity to aspirin, and we call that a triad. And that's just an example of how asthma can be different in some patients, and some patients with asthma have one particular constellation of symptoms. The scan that you see there is essentially a picture of the sinuses, and on the left, hopefully you can see around the sort of whirl pattern that reminds me of a cinnamon Danish, but I'm sure it's nothing like it. You see this large black field, which is essentially a sinus, a cavity, which is normal. But on the right, on the other side, you can see it's all opaque and grey, and that's blocked out. And that's someone whose sinuses are full of mucus and inflammation and blocked. And you can just imagine how difficult it must be for that patient to breathe in and out through their nostril. But the take-home message is to think of asthma as one complete airway, affecting both the upper airway and the lower airway, and symptoms of allergy, runny nose, sneezing. It's really important to help treat and manage those symptoms as well. Now, asthma as a whole has an incredibly large impact across the country, mostly for individuals who have asthma, but also their care providers. It's the most common respiratory condition. And because it's so common, I think doctors and nurses, and maybe even sometimes patients, we've all become a little bit complacent with asthma in some cases. And that can be potentially harmful, because although you may have symptoms that are quite mild, maybe not even taking daily medication, asthma has the ability to cause an acute attack in people, and sometimes without much warning. And so it's important that patients have an action plan, have the right inhaler, and can know when to seek medical attention, because the symptoms can come on over an hours and often short numbers of days. And if patients are not well prepared for that, then unfortunately they can have a really acute attack, having to see their GP or even come to the emergency department. And some patients even come to serious harm. There was a study in 2014 that highlighted the UK was really some way behind in terms of other countries and how we looked after with patients with asthma. A more recent study in 2024 also showed we've not made much progress. So with the new guidelines that have come out and webinars like this and other ways, we're all trying to help make sure that we deliver the better care and the best care we can with patients with asthma. So many of you will recognize the inhaler there, salbutamol. And salbutamol is one of the first inhalers and medicines that patients with asthma have been conventionally given. More and more patients should not be given salbutamol as their first inhaler. And the reason is that this study, this NRAD study, which is a really landmark world study in the UK, the first of its kind across the world, highlighted that so many patients were managing their asthma with only the use of a blue inhaler. That is an inhaler that's salbutamol, which is the active medicine. Sometimes it's given as Salamol or Ventolin, but they're all the same medicine, it's salbutamol. And just to give you an example of what good control represents, well, good control of asthma would be probably using only about 3 blue inhalers in a 12-month period. This study in 2014, which looked at all the patients who had unfortunately died with asthma, showed about 40%, 4 out of 10 patients who had died with asthma and were using 12 or more inhalers, of the blue inhalers, each year. And that's a marker that they had uncontrolled asthma. On the flip side of that, the preventer therapy, which has always been that brown inhaler that many patients have been on, that beclomethasone inhaler, about the same number of patients, about 40%, had 4 or less inhalers. And just to give you an example, if you'd had using your inhalers in the way that you'd expect to use it, you should probably be going through about 12 brown inhalers a year. That means 1 inhaler per month. And it just showed you back in 2014 how much we uncovered there through that study. And unfortunately, a lot of that remains the case. And that's where it's really important to move patients who are using their salbutamol to control asthma to actually prevent a therapy, which I'm going to talk about in a moment. So one of the key themes that through talks with doctors and nurses that all of us are trying to help support is reducing our dependency on salbutamol inhalers. So in the next 2 slides before I finish, I just wanted to give you some, I suppose, take homes in terms of how to live well with asthma, because I wanted to make this relevant and useful to as many people as possible. So like a lot of conditions, the general things still apply. And that means eating well and lots of fruit and vegetables because of the antioxidant properties. And generally that will make sure that you live with a healthy weight. Some foods can exacerbate asthma, certain preservatives, but usually those are things that individuals have a clear idea about. And sometimes you can get a food pollen syndrome when you've had with certain foods, which is slightly different to asthma. But broadly speaking, lots of fruit and veg and lots of things that you might sort of see in a Mediterranean type diet. It's really important to keep moving, to keep active with asthma. And if you feel that activity or exertion or exercise is affecting your asthma control, speak with your doctor, speak with your practice nurse, because it's a sign that your asthma is not well controlled. And for most patients who are getting symptoms of asthma when they're exercising, it means the asthma is under control, and it shouldn't mean that you do less. You should keep being active, but just have your asthma better controlled. Be kind to yourself. Asthma is a condition that can be difficult to manage and difficult to live with, and especially if you've had lots of medications and lots of steroids. And steroids, as we know, can lead to other changes in our bodies, in our mood. And a lot of patients who've had uncontrolled asthma have a lot of anxiety and depression, and it can be really tough living with that. And I think more and more of us recognize that and the impact that asthma has. Triggers are really important to think about. So the obvious things like smoking, vaping, sometimes open fires, sometimes candles, sometimes strong perfumes or smells, but things that are in the environment that you are likely to inhale that can irritate or exacerbate your asthma. We live now in the age of apps, and there are some good quality apps which provide you with an up-to-date evidence of what the pollen is like at the time, what the pollution is like. London Air is one such example. And you can use that, particularly if you find that the pollen or the environment or the climate or the weather is affecting your asthma control, just so that you know when might be a good day to exercise outdoors, when might be a day where it's less so good. Vaccinations, it's a key thing. I'm sure Nick would support that as well. And in asthma, most patients will be offered, with severe asthma, many patients will be offered a pneumococcal vaccination. And according to certain age and other health conditions, you may also be offered vaccinations against COVID-19 as well as influenza. And finally, I suppose the medicine, isn't it? And that's about using the right inhaler. And for many patients, that's going to be something like Foster, which you see using the pink inhaler, or Symbicort. Now, because of the format of today's talk, this is not really the right sort of forum to advise people about what medications you should be. That has to be with a healthcare professional who knows your health history and who can have that conversation with you. But I thought it would just be useful, given the new guidelines and trying to support as many people as possible, just to highlight 3 examples of how things have changed in these new guidelines. And now, if you're diagnosed with asthma, most patients will be offered medicines in line with the current guidelines. But if, for example, you were initially given inhalers some years ago or last year or the year before, you might find that when you next have your asthma review with your practice nurse, or if your asthma is uncontrolled, the doctors and nurses will support you with the more up-to-date practices. So some patients will see their healthcare practitioner and say, oh, I get a bit breathless or wheezy when I play sports or when I'm in front of my neighbor's cat or under certain situations. They're generally well, they've not had any attacks of their asthma, and they're offered an inhaler. Now, in the past, they may have been offered a blue inhaler, a salbutamol inhaler, and some of you may have that. But more and more patients will now be offered something like Foster or Symbicort because that has a preventer as well as something that will relieve your symptoms. And so case scenario number 2 is where you have a brown inhaler, you use that day in, day out, morning and evening, 12 hours apart. And then you use your blue inhaler as your rescue. Again, more and more patients who have that combination and have uncontrolled symptoms will be moved to something like using Foster or Symbicort on a more regular basis. And then finally, there'll be patients who have an inhaler like Foster or Symbicort. They use it day in, day out, but they use their blue inhaler as their rescue. Again, more and more patients will be advised to use their Foster or Symbicort, but as both their maintenance and as their reliever therapy. And I suppose in a very quick way, that's a sort of brief summary of the three case scenarios of how patients are given inhalers. Okay, I think that might be a good time to potentially hand over to Priscilla, if I may, and I'll be very happy to answer any questions or Q&A perhaps at the end of the meeting. Thanks.